are themselves in the private practice doing good work, so that they will also get chance to present in the ASU forum. Dr. Shengal Ryan sir also accepted the President ASU without any hesitation that this program should be done both webinar as well as in the ASU physical conference to be conducted at Vijayawada next month 10th to 13th, 11th to 13th of July. So I wish most of you who have joined will utilize this opportunity to listen, learn and share the knowledge. With this introduction, I will share about the Abhishek, who is the chairman. Can you share the screen? Dr. Abhishek, I personally know, he is close friend of me, very good academician. He is from the prestigious, no, Abhishek. He is from the prestigious institute. It's all right. It is from the prestigious institute Muljibai Patel Urology Hospital, and he is the managing editor World Journal of Urology, and he is also council member Robotic Urology Forum of India. He is proficient robotic surgeon and educator with 88 publications and 150 invited lectures. He is recipient of multiple prestigious awards, including the USA Best Poster Prize in 2022 and 23 consequently, and AUA Chakrabarti Fellowship 2023. Recognized for contributions to endourology, academic writing, and international collaborations. So with this introduction, I will also introduce our South Zone Youth Chairman, Abheesh Hegde, who is from the Mangaluru, and he is also consultant urologist now in Mangalore. So he is next. Our co-chairman is Dr. Gopal Tak, currently working at ASU Institute of Nephrology and Urology. Gopal Tak has done MNAMS and he is World Endourology Society recognized fellowship at Muljibai Patel Hospital, Nadiad. Completed DNB in MPUH, subspecialty interest, endourology, laparoscopy and robotic surgery. He has 20 publications to his credit and authored 4 book chapters and edited 1 ADPKD book, reviewer of various international journals, 24 national and 7 international projects. So all the 3 have great credentials to chair the session. Now I will hand over the program to initial comments by Dr. Abhishek Singh, and later the program will be taken over by Abheesh Hegde and Gopal Tak. Over to you, Abhishek, please.
Thank you very much, South Zone, the hierarchy, for giving us this opportunity. And President Sir and Secretary Sir, we at the Youth Organization of USA really appreciate your gesture of involving us in one of its kind program. Our young members headed by Dr. Abheesh and Dr. Gopal will surely do a great job of this program. And once again, I'd like to thank the South Zone for this wonderful opportunity. This entire webinar is going to revolve around the needs, aspirations, and ambitions of young urologists and how do we help them get there. So on that note, I hand over the proceedings to Dr. Abheesh and Dr. Gopal.
I also request Abhishek at the end give few comments. We'll appreciate that at the end of each talk. Please. Thank you.
Sure.
Over to you, Abheesh Hegde.
Yes, sir. Good evening, sir. I am working as an associate professor in urology at Father Medical College and as a consultant urologist in Bangalore. So, the entire idea, do we have Dr. Gopal Tak here?
Yes, yes.
Yeah, I'm here.
Yeah, I think Gopal sir can give an introduction about you, about what the activities are, and then we'll start up.
Okay.
Abheesh, did we lose you?
Yes, sir.
What is the first presentation? Give it.
Yeah. And Dr. Rohit is here?
Yeah, no problem.
Yeah,
okay.
Yeah, yes.
Fine. So I think yeah, Dr. Rohit, you are here, right? Can you connect your screen? So what the idea behind this, this was Dr. Waddi's idea, especially to encourage all of the speakers here. We have about 9 speakers. All of them are, are practicing at different settings in different cities, in medical colleges, in corporate hospitals. Some of them are post fellowship. Our idea is to give everybody a chance to talk to for as many people as possible, so that they can showcase their work. A lot of good work is happening. A lot of young urologists are doing a lot of good work, which they probably do not get a chance to go and showcase it somewhere. They may not be able to attend all the conferences. The aim from you. Which is the Youth Organization of Urology under the USI, is to provide a platform for everybody to come present their work, try and find some collaborators, do some research. Anything after that, it's all up to y'all. Where y'all want to take it after that, it's up to y'all. So without much ado, since we are already we'll have a tight schedule and we've got a lot of speakers speaking, we can all the seniors can come in whenever after each talk. Dr. Rohit, are you ready with your presentation? Is your slide?
I'm ready. Yes. Yeah.
Is everything connected? Yeah, I think we shall start. Dr. Rohit and Dr. Shreyas, I know they're very we are all in a very close vicinity. Both of them are very enthusiastic urologists who started. Dr. Shreyas, of course, has joined our team itself, so I know him very closely. We'll start with Dr. Rohit, who did his MCH urology from INU Bangalore, and is into practice for about 2 years now. He's in Sirsi, which is almost a 3-tier city. Rest of it, obviously, he should be able to tell you. He's here to talk about freelancing fresher in a 3rd-tier city, the struggles and the positives. So over to you, Dr. Rohit.
Am I audible? Hello?
Yes, you're audible. Your slides are visible. Please go ahead.
Yeah. Thank you, everyone, and I would thank South Zone for providing me this opportunity. Without wasting much time, I will proceed with my talk. It's all about freelancing pressure. As soon as we come out from our institutes, we face.
You are not audible, I think.
Hello?
Yeah.
Hello?
Please go ahead.
Yeah.
And
Now we can hear you.
Yeah. So the problems, as soon as we come out from our institutes, especially when we enter that 3-tier city, I am here to represent the rural India from the beginning. So many of you might not be knowing where I practice, like Sirsi. It comes near the coastal belt of the Karnataka. So this is where I practice, and whatever I am sharing today, it's all on my experience pertaining to my city, and it might vary from person to person and city to city. So in this 10 minutes talk, I'll just briefly explain the experiences of a freelancing fresher in a 3-tier city. Most of us, when we start freelancing, we will have these struggles that most of the hospitals, especially in a small centers, will not have any urological instruments and setups. Basically, they will just provide us one bed and an anesthetist and their equipment. That's all. So rest all we have to carry. At least in bigger cities, we have the option of renting the camera, monitor, or at least some cautery machines. But here, in the downer you go towards cities, we have to carry everything. In fact, I have to carry a Romovac drain. I had to carry suction drains also, and sometimes you face so much difficulties. There was no drain. I used my Eurosac bag as the drain. So all these newer innovations will come when you are faced to struggle all these things. Next, when you are a fresher, the main thing what we are entering is the main empire of general practitioners, where everybody treats everything here. So they don't say, I don't treat this. They might be right from the Ayurvedic practitioner, homeopathic, or MBBS practitioners who are here since 30 years or more. They don't refer. So they treat everything. For example, I have a physician who was treating a 2-centimeter pelvic calculus for 1 year. Every month he used to go, he used to do a screening. He says there is a 1 mm reduction in size and you take this medicine. So at the end, when it blocked and when he came with the pyonephrosis, that's when our struggle starts. And for all of us, at the beginning, it's very difficult to gain the trust of the patients, because if I suggest patient regarding you need surgery, they will listen to the neighbor more than the doctor. So if the neighbor says you go to that doctor, they will listen. Rather than me saying, no, this is emergency surgery, they will not. So the main thing comes to us when we are practicing in a distant areas or a rural practice, it's all about gaining the trust and sitting at one place. And the next problem what I have faced or I have seen facing is patient education. Patient doesn't know when to consult a urologist, because they all these years, all these decades, they have been like going to a single person as a general practitioners. Whatever happens, they go. Be it a fracture, be it a head injury, or be it a UTI, they go to the same person. So they don't know when to consult a urologist. So it's main difficulty what we face when we come out of our institutes is to educate the patient that when I'm going to pitch in, when the urologist is going to help you. So this education mainly we are doing through many camps, or telling the patients that this is where the urology stands in. Next, when I come to a point of tier 3 city, the main thing which we face is there is not much urologists. The main thing which we face is backup. So that's why we are afraid to do difficult cases. That's why we are afraid to take challenging or the bigger cases where in case if I get stuck in between, so what to do? So I can't refer, I don't get a friend who can come in between the surgery, or we might maximum we can get is a general surgeon who has been practicing. That's the maximum help we can get in a distant rural areas. Second thing is we have to plan all our consumables, and be it stents or guide wires or amplast sheath or emergency. Sometimes the forceps might break. So all these things we might have to plan at least 3 days prior, and also as early as possible. It is a must to procure our second set of instruments, because we don't know when the instruments will stop working. Suddenly, last few days before, my suddenly foot switch stopped working. So I had to remove that, and I had to learn all the emergency jugards to do the short in the litho class, so that it worked as a foot switch. So all this emergency jugards we will learn when we are at the problems are at to our neck. The coming to the finances, what the difficulties we face in tier 3 cities is the paying capacity is low. So most of the times we are forced to do surgeries for the lesser cost, if not at the loss but at the lesser cost, because it's all about numbers. If I have to gain the trust of the patient, I have to show them the results. If I have to show them the result, I have to do bigger numbers. So bigger numbers will come only if I am doing at a lesser cost. So these are the drawbacks or the practical problems which we face at the initial days, because later, when we reach a point where we can say, no, this is a must, so patient might listen once I gain the trust. But the initial part, this is one problem which we face. And second, when we come to the rural areas, most of them are very negligent about having the insurance. The private insurance part is very less here. Whoever are having the insurance, they feel that they will go to a bigger cities and they will get it done in a corporates, because the service is better and all those things. But the patients who doesn't have insurance, they will fall into that low paying capacity pool, and where we might have to face the difficulties. Next is many hospitals don't take these schemes like in Ayushman schemes, because they feel one thing is the money will come after 6 months to 8 months, so it is very difficult for them to run this hospital. And second thing is the number. If the urologist is providing them the number, then they are okay with it. But the urologist is not there round the clock, and if they feel urology patients are not going to come, so they feel it's lost for them. So Ayushman scheme, it's very limited hospitals, so that's also will become one problem. The other thing which I have noticed here in where I am practicing is time is not money for many people. So if you are a working class and if you have to join to your work sooner, so you will want to get the treatment faster. So here, mainly the farmers or the people who have their leisure of time, they feel like 1 centimeter stone will pass. So this too shall pass. This is the concept, and there are a lot of quacks and herbal medications that they are being followed. I've seen people like 2 centimeter stone, he wanted it to pass on its own. So waited for 6 months, every monthly one scan. So it won't pass. And the neighbor would have said, I have passed a 2.5 centimeter stone, this will pass. So he will just wait. For him, time is not money. He can wait with pain, he will wait. So that's the one problem what we have faced here. And the second thing is the small geography, where word of mouth spreads very fast. So if you are good, you will get a very good response. If one case fails, same way it spreads like a wildfire. So have to be very cautious in the initial days where to choose the cases. So the simple cases, non-complicated cases where I feel this doesn't require much of post-operative intervention. So that's when the smartness of the practitioner who is practicing in tier 3 cities or as a freelancer comes in. But it comes with its own advantages. I'm not saying it's all the problems so we are our own bosses. We can choose and we can decide what patients, what surgery I want to do, and the leisure at what I am going to do. Patients can wait, and we have a give a good quality of service what we are uh, provided with. Second thing is we have the virgin playground to play around. So we can explore. There are a lot of untouched areas, or there are places where I can provide services by traveling. Just now, I came from a place called Sagra, which is around 70 kilometers from my place. So I went there in the morning OPD. I finished. I went there. I had a surgery there. I saw OPDs and came back. So these services I can do because there are no urologists present there. So these are the advantages, still advantages we have. And also, if you have other passions, so we can do that. This is my own nursery in my home where we have grown saplings of pepper, and this is me practicing cricket with a mango sapling with my dad. So it all comes with its own advantages. We all know, to conclude, that time is the best teacher. So if we sit at one place, just like even Chandramohan Vaddi sir has sat one place for years, he has practiced. He might have seen the empty OPDs in the beginning of his career. Same way, we are at the beginning. We still have a long way to go. If we sit at one place, provide good service and ethical service, I think wherever we are, we can give a better service and we can succeed. That's what I wanted to say and conclude. Thank you, sir. Thank you, South Zone, for providing me this opportunity, and special thanks to Abheesh for giving this opportunity. Thank you, sir.
Yeah. Thank you, Rohit. Wonderfully spoken. One or two doubts. Somebody has asked in the chat box, what are the common cities? What are the common surgeries that you're doing in a third tier city?
So third tier, mainly bread and butter is URSL, TRP, and PCNL. These things. So right now, I don't have the facility for RIRS. So I don't have the laser machine. So I'm not equipped. And nephrectomy and pyeloplasties are the two open surgeries which I am doing. So still recently, I went to IMAST with Abhishek sir. So yet to explore for the lab. I'm just trying for that.
Correct.
So basic thing is URSL, TRP, and PCNL.
Rohit, Abheesh, one comment I like to do. This is close to my heart. All of us, including me, as he said, I was a freelancer for 3 to 4 years. After that, OPD for 3 to 4 years. After 7 years, I started a daycare center. So, for the freelancers, my advice is that 3 advices I will give you. Most important is, without knowing the case, and after going, don't give anesthesia before you go. You do it. Initially, you have to earn money. Don't do the case without giving anesthesia. You read 5 minutes, you spend time. After that, you sleep and then do the case. Number 2, travel during the night time, avoid. For example, 8 o'clock, 9 o'clock, don't keep the case. Early morning 6 you keep, and 11 o'clock you come back. And number 3, at least yearly once, please check your blood pressure and blood sugar. These are my 3 suggestions. When I was a freelancer, I used to get headache and all that. After that, it subsided everything. But during this time, between 35 to 45, significant changes happen in your body because of stress. One is earning money, competition, not able to do cases, colleagues, peer competition. So please take care of your health. Recently, we have seen mishaps in our Hyderabad only. These are my 3 suggestions. Know the case before you do it. Number 2, don't do the nighttime case. Number 3, regular checkup, at least blood pressure. Because those who travel regularly outside more than 150 kilometers, prone for diastolic hypertension. And regular exercise like gym will decrease it. This is my suggestion. Thank you for this.
You, sir.
Right.
Thank you.
Yes, one question from my side, Dr. Rohit. How much do you travel every day?
I don't travel every day. I have fixed my traveling for 2 days a week, where like Wednesdays, I go to a city which is 70 kilometers from my place. And Friday, I go to another
Right.
place which is around 50 to 60 kilometers. So
So
other
you
days
yeah.
I made sure that in my center, which is a OPD and daycare center, I made sure that I am available all the week. Every day I am available, so that I don't miss
Yeah.
out the patients where I am practicing and where I have planned to build my practice in future.
Correct.
Yes, correct. And I think this is something that was told to me when we started practice, that there are three things that somebody is looking at when they come to you. The most important thing is your availability. That is A. Then it's the affability, and then your knowledge and everything comes later. So it's your availability that's important. So right, let's go to Dr. Shreyas. Very
Abhish, I'll just make
enthusiastic.
a
Yes,
short comment on this
yes, sir.
freelancing thing. When
Yes, sir.
you, yes, you can, Shiresh, you can start loading your screen
Yeah,
now.
Yes,
yeah.
sir. Yes. On.
So
Full
one
screen.
is if you know that you are going to go to a smaller place and start freelancing, you start planning during your residency. So how do you plan? I don't mean to say that you start to plan your practice. What you can plan is whenever you are doing a case, select instruments by yourself, keep a list of the instruments that are required. Like in MPUH, Dr. Snehal Shah was there a long time back. What he would do is he would tell the resident, go pick your instruments before the case. And once you start the case, you're not allowed to take anything. So by doing such an exercise, you can get used to keep taking care of your own set of instruments. That means you decide that you need 1, 2, 3, 4, 5 instruments. When I used to freelance in Bombay, I had a note for every surgery, and I used to check all the instruments before going for a surgery. And I concur with Chandramohan sir, because I did this mistake. I had to be back hospital at 8 a.m. in the morning. So sometimes I used to start at 2 a.m., 3 a.m., go to Ulhasnagar, operate and come back. So this is not that you should be doing. Regarding cost, you should trust yourself. What you're saying in all fairness is correct. Look into the eyes of the patient and honestly say that these are my charges. You should not be afraid of telling that these are my charges, and you should not be afraid at all that the patient will go away. Just be honest and say what you have to say, and rest is up to the patient. Don't worry about the instrument malfunction thing. People who have a robot are also worried that the one arm of robot is going to Kong off and you will not be able to complete a case. So that is something that as destiny has in store for you. All you can do is be very well prepared. So check your instruments prior, condition them every time, and leave rest to destiny. And just go ahead and do your job. Shreyas, please go ahead.
Good evening, everybody. Thank you for ASU and you, the office bearers, for giving me this opportunity. So I'll be talking about a young urologist dilemma to pursue robotics or laparoscopy. There's no disclosures, no conflict of interest. So yes, the debate was open versus minimally invasive surgery. So right now the debate of the day is robotic versus lap. So I'll be purely speaking from my perspective. That's my point of view, and probably inputs from few of my colleagues and seniors and friends. So I was basically trained in RML Hospital, New Delhi. We had a good exposure in lab. There was a lot of resources at disposal, except that we didn't have a robot. So my experience with robot is nil. Currently, I'm working in a tier 2 city, that is Mangalore. We have close to 10 medical colleges in a small place with about 40 urologists, and there are about 3 to 4 robots in Mangalore. And should I train lab? What is the reason? So mostly, most of the cases that we do or deal with in a daily basis can be dealt with lab, and we have easy access to it. Most of the medical colleges or the hospitals, they have good lab equipments. It is cheaper to acquire, and it falls cheaper for the patient as well. There is a significant cost, benefit for the patient. Like for example, an open lab procedure, lab nephrectomy, will cost only about 20,000 more in our institute, and even the accessories are affordable and easily available as well. Also, the patients are more aware about the laparoscopic procedures. They have more idea of what it is and what can be done. And for the surgeon's point of view, it has a shorter learning curve. training is easily available. Most of the centers where you're trained or where you do your MCH or DNB will have good laparoscopic training, or at least a decent laparoscopic training with the hands-on experience. Also, I think if you have a good, lab training in your MS or DNB days, surgery days, that also will help. Why robo? So it's definitely here to stay. It's not just a future, but it is here to stay. And the use is increasing in tier 2 and tier 3 cities as well. And the patient's demands is increasing because of increasing awareness. So they're asking for more of robotic surgeries. Like some patients, they feel that getting operated by a robo is a prestige issue. And for a surgeon, it is a great boon in terms of economics and comfort, with technical aspects like 3D vision, magnification, and tremor cancellations. And few steps like suturing, which is which makes you sweat in laparoscopy, are made very easy, like suturing in robotics. And most of the studies say that they are both comparable. A recent study or a critical review by Professor Anand Kumar in 2024, they say that they have almost parallel outcomes between robotic and conventional laparoscopic urologic surgeries. Most of the common urological procedures, they have similar results. And they say that lab still, is a mainstay if you are working in any setup in a developing country like India. So when it comes to our training days, so we know most of the institutes train in lab, they give good hands-on training as well. And as I already said, MS and DNB general surgery training also adds to your laparoscopic skills. But in India right now, there's no routine robotic exposure to most of the trainees. And even if they are exposed to robotic surgeries or robotic urology training, they do not have hands-on, a lot of hands-on experience. And immediately after your MCH or DNB, you usually tend to go back to your hometown. And because of the rising number of urologists, you have that constant pressure that you will have to go to your hometown, and get settled there as early as possible. So then again, you feel that your robotic training for a year or two might go in vain. And I feel that the location of the practice, your colleagues, the institution where you're working, the institutional environment, the support they are able to provide you, and the resources available will make a lot of difference. The most important thing here is the patient factors. So you have to look at the economic status of the patients, the schemes available, even the private or the government schemes. Most of the schemes, they do not, are okay with the robotic procedures. So this is a very important thing, as Dr. Already said, the previous speaker already said. And patient knowledge, understanding, and expectations are also an important thing that we'll have to look into. So finally, I spoke to a few of my seniors and colleagues and friends who are doing robotic training, and they feel that we'll have to train in both. Lab is a must, and you'll have a basic idea of what, even when you're going into a robotic training, your lab knowledge will give you a better understanding of what you're going to do. Some of them, they still consider robotics a luxury and not as a necessity. And they feel that after robotic training, lab is doable. Like they can, deal with most of the cases. But the ones who have received only robotic, once they have finished the post-lab laparoscopic training, robotics, it still needs a lot of work to be done. And also it depends on your place of work and the patients you deal with or the patients you treat. And still they feel that the robot is the future. Thank you.
Right. Thank you, Dr. Shreyas. So, anything that you did specially to nurture your laparoscopy skills during your residency, after your residency? Was there anything, anything about the instruments that you were very interested in during your this thing, or was it that it was just generally it was part of your training, so you went with it?
So it was part of our training itself. So we used to, unless it was, absolutely not possible that we proceed laparoscopically, we had to start it as a laparoscopic way. And then in case we cannot proceed, then we had to open it. So every case, however difficult it was, we had to proceed laparoscopically. And we had a good number of cases, and our consultants were really good lab-wise. So we had enough and more number of cases that we could train with.
One
And
I think Vaddi sir
in
wanted to make a point.
small
Yes,
point.
yes.
We also did not add laparoscopy during PGI when I finished my MCH. So I used to do one nephrectomy per year, one pyeloplasty per year. It used to take 3-4 hours. The present generation will not have cases that many to practice on the patients. So my suggestion is he got trained in the Ramanohar Loya, but those who are not trained in laparoscopy, so when you go immediately after MCH, before going to private practice, if you are interested, work 6 months with anybody at any cost. That will make mentorship will make 5 to 10 years reduced to 5 to 6 months. This is my suggestion.
yes.
So, okay.
So since we are Abhish, since we'll end this session at this point, and then we're going to change track and make one comment on this. See, the value of learning or seeing something is extremely aspirational. So if you see a robot during your residency, or you see a laparoscopic program, and you're not given any hands-on, so don't be bogged down. If you get to see something, if you get to assess something, this is a gold mine opportunity.
Yeah.
Just grab it. When I was in KEM hospital, the laparoscopic program was so redundant there that Sujata madam herself started developing the program with me. She used to do a case, allowed me to assist, and sometimes she used to assist me. I was fortunate that I had one of the best teachers. Everybody may not have that fortune that she will start learning with you. But then there were other people. There was Dr. Anup Ramani in Bombay City. There was Dr. Pradeep Rao, who always allowed access into their operating rooms. I could just knock into their operating rooms and go. So you will find such good people all around you. You will only find a teacher if you seek for a teacher. The teacher is not going to come to your house. So imagine anybody and you approach him that I want to learn. At the most, he may not be in a position to give you some stipend, or he may not be in a position to pay you, but he'll always be ready to teach you. So find a teacher, find a mentor, and start following him, even if you cannot do a formal fellowship with him.
Right. So I think also for consultants who are, probably already into practice, don't have the time. Something that a lot of my seniors told me, and also in my personal experience, you need to have one or two colleagues of yours whom you're close to, not just to, as one, obviously as friends, as we've already seen, but more importantly, who can help you in your learning. As a group, you might think twice to do a risky surgery, or difficult surgery, or complicated surgery, but as a team, it really takes the stress off you when you're doing it. Even if it is a remote location, you're trying to do a major surgery in a remote location, you're in an institute, you'll have to utilize your colleagues, because your learning curves, I think it just takes a different path. Any other inputs? Yeah, so we'll go on to the next talk. Dr. Ravi, I think you're ready. The talk is on intravesical chemotherapy, recent advances. So Dr. Ravi is my close friend for a long time now, since our post-MS days. So he's also an assistant professor in the Government Medical College. More over to him for more of his talk.
Good evening, everyone. Thank you, Abhish and South Zone. Thank you, Chandramohan sir, for giving me this opportunity. Today, we'll speak about intravesical chemotherapy in CA bladder. The purpose of this talk is we know only about BCG, and there are certain things which we should know beyond BCG. And the disclaimer is BCG is gold standard as per guidelines till today. And the need for intravesical therapy is that there are some side effects with BCG, and there are some problems with BCG which we should know. And nowadays there is shortage of BCG, and the dose which we are getting is different, and the dose which the abroad people are getting is different. The strain is different, and the solution for this is intravesical chemotherapy. And we will discuss intravesical chemotherapy in two things, like perioperative role and as in definitive management. Perioperative role, as we know, after TURBT, if it is low risk, if it is small one single dose of mitomycin 40 mg, which is to be given like within 24 hours. If it is given within 6 hours, it will be best, and it is a chemotherapeutic agent. It can be given like in standard dose, standard format, or it can be like in electromotive or thermal thing. So standard we use in all the cases, like If it is complete resection and there is no bleeding and there is no risk of perforation, and if you are not suspecting any urinary extravasation, then give 40 mg in 40 cc sterile water and clamp the urinary bladder for at least 45 to 60 minutes. And electromotive thing, I'm not sure whether it is available in India or not. There will be leads which will be kept over the suprapubic region, and it will increase the bioabsorbability of the mitomycin. And the same thing, thermo MMC, which is given by BST device like 2000 hyperthermia. The same thing here, the bladder will be heated to 42 degrees Celsius for 40 to 60 minutes. Here the schedule is little different. Like normally that single thing, perioperative mitomycin is a single thing. These are for definitive management, 6 weekly sessions followed by 4 monthly sessions. And these are some contraindications which we have already seen, like bladder perforation if the patient is having hypersensitivity to mitomycin. And coming to the definitive management, like in BCG naive setting, in an intermediate risk NMIBC, where MMC can be given as alternative to BCG, because with the BCG side effects will be more. Whereas with mitomycin, the side effect profile is less. Here also it is like 40 mg dose, and first for weekly doses for 6 weeks, and then 6 weekly and monthly doses for 12 months. And coming to the main thing, like gemcitabine docetaxel, it is sequential. First we'll give gemcitabine in the same setting and then docetaxel. We'll see how they are giving. This is a meta-analysis which was published recently by our colleagues from BHU. They are compared in BCG naive setting, BCG versus gemdosi, and the clinical recurrence was slightly lower with gemdosi, but it is not statistically significant, but the side effects were very less compared to BCG group. And the best thing is they have most patients have completed the gemdosi therapy than the BCG therapy. BCG, we have a paper from TMH which was recently accepted at BJUA. In that paper, like from 2020 to 2022, only 34% patients had received like adequate dose of BCG because of side effect profile. And coming to the dosing, first we'll give gemcitabine in 1 gram in 50 ml NS and retain it for 60 to 90 minutes, and then empty the bladder, and then give 37.5 mg of docetaxel in the same thing, and I ask the patient to retain it for 90 to 120 minutes. And the schedule is like first weekly doses for 6 weeks and then monthly for 24 months. And this is one study where they have compared gemdosi with BCG, and recurrence-free survival at 24 months is around 81% with gemdosi. And toxicity is very less. Most of them are like grade 1 and grade 2, and most common is like increased frequency and urgency. Whereas with BCG, there will be a lot of toxicity, and most patients may not survive, mostly the elderly age group. And here 94% had completed induction with gemdosi. And coming to the other things, like we have spoken about BCG naive setting. Now this is like BCG failure. These are the different categories which is out of our thing. In general, if it is like BCG unresponsive or thing, as per guidelines, the best thing is to go for radical cystectomy. If the patient is not fit for radical cystectomy, or if the patient is not willing, then we can offer the intravesical chemotherapies like this. And this is the study where they have already patient have received BCG and now gemdosi has been given. Here you can see cancer specific survival of 91% at 5 years. This was the schedule. And coming to the novel intravesical therapies, I'm not sure whether these are available in India or not. These are like osmotic pumps, TAR20 and 210. These are like semi-permeable silicone 5 centimeter stents, which will be pushed into the bladder via cystoscopy, and they will be left inside the bladder. They will get absorbed inside, and there are like thermo gels. They're also similar to that, which will be kept intravesically. And it will be this TAR200. It has to be repeated for every 3 weeks. We'll see what all are there inside. And there are certain viruses also which are being used, and these are all like FDA approved. And this TAR200, which contains gemcitabine, and the side effect profile is very less. The advantage with this is it is being used in NMIBC setting as well as in MIBC setting. In MIBC, if the patient is not fit for cystectomy, there also the 12 months progression-free survival is around 70%, which is better compared if the patient is not willing for radical cystectomy. And this is TAR210. This contains erdafitinib, and which is like FGFR kinase inhibitor. And here in intermediate risk NMIBC, there is 3-month complete response of 82%. And there are like some other things, photodynamic therapy, which is TLD 1433. It is ruthenium based. Here in the patient will be in general anesthesia and the laser will be inserted into the bladder and it will be activated, which creates like singlet oxygen and radical oxygen species, which will kill the cancer cells. There was complete response in 54% of the patients. And this is adenovirus, Cretostimogene grenadenorepvec. And this is also given intravesically, and it is mixed with 100 ml of maltoside. And the best part is in BCG unresponsive CIS, there was complete response of 83% at any time. In BCG refractory NIBBC, overall complete response was 47%. If the patient is having BCG unresponsive high risk NMIBC, there was a study which showed that pembrolizumab combination with this cretostimogene had demonstrated the highest 2 years complete response. And previously there was like metastatic CA prostate where we speak about castrate sensitive and castrate resistant. Now what all we are seen for BCG unresponsive, what all we have tried like gemdosi, pembrolizumab, everything we can try for BCG naive settings. And this is a simple thing which compares BCG versus gemdosi in general. The oncological efficacy is the same, whereas the toxicity is very less compared to BCG and discontinuation rate is very less compared to BCG because of less side effects. Ease of administration is there. Availability, gemcitabine and docetaxel is more freely available than BCG, but the cost is more because there are two drugs and the combination is more. But the side effect profile is very less, so the patient doesn't have to spend more money on bladder relaxants, alkalizers, and the thing. As per 2025, only BCG is approved and MMC mitomycin is approved for only intermediate risk. If the patient is BCG unresponsive as per AU 2025 also, then we have to advise the patient for radical cystectomy. And if the patient is not fit for cystectomy, then we can advise the patient for intravesical sequential gemdosi. And this is the future of bladder preservation. Otherwise, I've seen many patients in my place, like which were treated by medical oncologists or some surgical oncologists, like NMIBC patients. They have treated with chemoradiation, even for low risk NMIBC. I'm not sure whether they have done because of unawareness or because that is the only thing they get in like state scheme. Thank you.
Right.
Thank you, Ravi.
Thank you, sir.
Abheesh, you have any questions? Gopal,
Uh,
Abheesh.
Nothing in the chat box, I think, sir.
What
So,
So
Ravi,
as
when
a
people
routine,
ask you,
yes,
Sir,
Dr. Gopal, sir.
sir.
NMIBC, what is your advice? You will go for BCG or you will go for Gemdosi?
If the patient is fit, I prefer BCG and that too not 120. Based on the patient side effect profile, I can start with 40 or 80. If the patient is elderly, then better to go with gemdosi, sir, based on the risk.
Okay, so BCG is still option for you.
Yeah, just still because I'm in a place like most of the patients are scheme dependent. So I have to consider that also. Like BCG comes in scheme.
Okay.
So I have a few comments to make.
Sir.
See, first thing is that BCG, we should not forget that it is still the gold standard as far as the effect is concerned. See, the best disease-free survival, progression-free survival is achieved by BCG, period. There is no discussion on this. There cannot be any discussion until we have a better product available. Problem is that BCG is extremely toxic. And furthermore, the problem is with the Moscow strain. 120 milligrams of Moscow strain is too much of a dose. The total amount of dose required is 10 to the power 8 to 10 to the power 9 colony forming units, which is present in only 40 milligrams of Moscow. See, this dose of 120 milligrams was calculated based on this colony forming units, which was 10 to the power 8 to 10 to the power 9 and 120 milligram of Tice or Armand Frappier. Here, the same dose is available in 40 milligram of Moscow, and we still keep on giving 120 milligrams. Therefore, Indian bladders were burning. Not that bladders don't get burned with Tice or Armand Frappier, but the effect is far more worse with MOS4. Therefore, there is an urgent need to look for something else. All said and done, sequential therapy is the second best option. And you are right in saying that you tell this to your patient, and if you think that he is not going to take this, then you better start him on a combination therapy. It is a myth that docetaxel doesn't burn bladders. It burns bladders. Only thing is the frequency at which it burns bladders is far lesser than BCG. It will be 1 in 10, 1 in 20. But when it burns bladders badly. Mitomycin burns bladder, but the frequency is very less. You'll get 1 in 15, 1 in 20 patients with suffers. When you give a sequential therapy, you should first instill local anesthetic agent, which can be a mixture of lignocaine and bupivacaine, along with some soda bicarb, hold it for 20 minutes and then start sequential therapy. One more agent which is very, very important, at least from a European standpoint, is valrubicin. So when you talk about intravesical chemotherapy, valrubicin may be potentially available in India. 800 milligrams of valrubicin can be used as a single agent for intravesical chemotherapy. When you use gemcitabine as a single agent, the dose is different as compared to when you use it in combination. When you use it as a single agent, the dose is about 2 grams. When you use it as a single agent, it is 1 gram. So this is also something worth remembering. So these were the few comments that I had. Over to you, Gopal and Abheesh.
Right, sir. I think that's about it. Let's move on to the next talk. That is by Dr. Hemnath, who's a consultant urologist at Preeti Urology Hospital in Hyderabad. He's going to talk to us about off-clamp robotic partial nephrectomy. Over to you, Dr. Hemnath.
Good evening, seniors and friends. A special thanks to my teachers, Dr. Chengalvarayan sir and Chandramohan sir, and also Dr. Abhishek for giving me this opportunity. So I'm going to talk about off-clamp robotic or laparoscopic partial nephrectomy. So we all will agree upon the fact that partial nephrectomy is the treatment of choice for small renal masses as of now because of its equivalent oncological outcomes, and it better preserves the renal function in the long run, thereby reducing the cardiovascular morbidity for the patients. But still, we are worried about one thing in minimally invasive partial nephrectomy, that is the warm ischemia time. Because of the fact that there is no agreed upon cutoff or a dichotomous value below which we can say it is safe and above which we can say that it is unsafe. It is still debated a lot by urologists. So most of the authors have agreed upon a value of 20 to 25 minutes below which it is safe. And most of the authors have told that more than 30 minutes is unsafe. But some papers have told that even a minute of warm ischemia is detrimental to the kidney function because it causes a lot of irreversible damage to the kidney in the cellular level. So every minute also counts. So, and also we should consider the fact that most of our renal carcinoma patients are having an underlying CKD. Most of the patients are diabetic, most of them are hypertensive. So up to 30% of the RCC patients can have an underlying masked CKD. So this pushed us towards something like off-clamp partial nephrectomy. It's not something new. This paper is published in 2010. They have done a study from 1987 to 2009 and compared patients with off-clamp and on-clamp, and they agreed upon arrived on three results. That is, one is oncological outcome is similar. There is a little bit of higher bleeding chances in off-clamp technique, that is acceptable bleeding, and also the important thing is that the decline of eGFR is very less when compared to the on-clamp partial nephrectomy. So this is replicated into the minimally invasive techniques like laparoscopy and robotics. Gill et al. They published this paper in 2014, 2011, and they have demonstrated 100% oncological safety, and also in 98% of the patients they are able to complete in off-clamp method by micro dissection technique. They have isolated the artery that is supplying the tumor, and then they clamped, and then they proceeded with the partial nephrectomy. So also then came up a lot of papers like retrospective analysis, systematic reviews and meta-analysis, even though they are not that, the strength of the studies were not that great, but still we have to take these studies into account. And they all agreed upon that the off-clamp technique, the EGFR decline is much less when compared to the on-clamp technique, and also providing equivalent oncological outcomes. Till now, we were following these strategies to reduce warm ischemia, like selective clamping of the feeding vessel, or early declamping after the inner rhinography, or sometimes we do only clamping of the artery and leaving the veins, so thereby some retrograde flow will be maintained throughout the surgery, thereby reducing the ischemia. And the extreme end of that spectrum is the off-clamp partial nephrectomy, where we are balancing both the things. So the patient selection for this procedure is very important, because this by no means is an easy procedure. This has to be one of the toughest surgery in urology. In the pyramid, it has to be on the top, because there will be more chance of bleeding and there will be emergencies. So we have to select the patients carefully. Better to select exophytic tumor, that is T1A. Most of the tumor is exophytic and with very less complexity score. And some relative indications, like patients having a pre-existing CKD or a solitary kidney or a bilateral renal masses. And also the patient should be fit enough to face the complications like bleeding. So the younger patients are better. And in the preoperative evaluation, the CT with good imaging is important, CT or MRI. With a very good 3D reconstruction, if it is available, it's very good, so that we will know the exact location of the tumor and its relationship to the collecting system and also the vessels. So coming to the technique, most of the surgery is similar to what we do, the routine on-clamp partial nephrectomy till the hilum dissection, and also the identification of the vessels and looping of vessels. In case of emergency, we need to clamp those vessels. So better to isolate the vessels, dissect and keep a loop ready. And judicious use of intraoperative ultrasound, if available, is of utmost importance. And the hemostatic agents, if it is available, will be helpful for the hemostasis. And rapid rhinography is important. So we should have extreme suturing skills to control these bleeders. So as I told you, this is by no means a clean surgery. It's going to be messy. The bleeding risk in all the studies that they are told that slightly higher, but it is not of much significance. And tumor resection duration may be high, but that's not going to be important. Positive surgical margins, if we are not having a good vision, there is a risk of breaching the margins, and complications like urine leak is possible. So meticulous closure is important. And overall complications in the studies have shown a similar outcomes. So this patient, I'll show a video of left side renal mass with a Bosniak type 1 cyst below it. It's a 2.5 centimeter with a renal score of 5A. So we have done robotic partial nephrectomy off-clamp method with the SSI mantra. So as I told you, the dissection of renal hilum is very important. We can do without a dissection, but it should not be the primary aim. We should be able to, this patient had 3 renal arteries, 1 major and 2 accessory arteries. So we isolated all the vessels. Our primary aim was not to do an off-clamp technique, but after seeing the tumor and its number of arteries that are there, 3 to 4 arteries are there. So we thought we'll do a off-clamp technique. So above the renal vein, 1 major artery was there. And the next step would be to free of all the surrounding fat. Here you can see that cyst is also there. So that cyst was used as one of the lower margins. So only the fat over the tumor is kept, mainly to hold the tumor and to have a control and to have a traction. And this cyst helped as a lower margin. And then marking is done. So the robotic technology with the improved vision and dexterity is very helpful in these situations. So all around marking is very important, because if you have bleeding and then you will not be able to see the other end of the tumor and you will be lost. So slow meticulous dissection is carried out, and there will be messy field, but we should be able to see the margin properly, and we should finish off as soon as possible, because the bleeding can be more sometimes, and some temporary pressure can be given. And also important is pharmacological hypotension by the anesthetist. Good anesthesia team will be helpful. So hypotension, intraoperative hypotension is of very much useful in these situations to reduce the bleeding. And a barbed suture with sliding technique of the clips will be faster than using non-barbed sutures. And good assistance is also very important, because they need to suck and show the clear field for you to suture. And suturing skills has to be top notch to finish off these cases without much complications. So next case is a AML with a large tumor in the superior aspect and a small tumor below it. In these cases, we do clamping for the on-clamp technique for the major mass, and we will release the clamp, and these small tumors can be tackled off-clamp method. So this is also one way of doing off-clamp, so that the warm ischemia time will be reduced. The complex tumors are first dealt with, and then these small tumors can be we can do it later on with off-clamp technique. So this is a 2 centimeter small AML that is below the big mass. The superior mass is first tackled, and then this one is removed later. So the benefits, as I told you, it's superior in terms of renal function preservation. The immediate postoperative eGFR decline is much less, and also the long-term results also showing promising outcomes. And the important thing is that oncologically there is no problems with this off-clamp techniques. So the important thing to note is that with the availability of AI, artificial intelligence, and augmented reality, and also the NIRF, the near infrared fluorescence vision, we can take this further up a notch and include a lot of complex tumors also for off-clamp technique, if as and when feasible. So 3D reconstruction, and also a word about the hemostatic agents like Verised patch that can be used to avoid bleeding and also to avoid rhinorrhaphy as completely also. And hemostatic agents like FlowSeal, Surgicel, also they are also helpful in these situations. So to conclude, consider off-clamp technique for small exophytic non-hilar tumors. With the AI coming up in a big way, these indications can be expanded to include a lot of patients to preserve the renal function. The results are and the oncological outcome is similar to what we do in the on-clamp technique. Thank you for the opportunity.
Right. We don't have any questions from the audience. Anybody from in the chats? Any comments from Dr. Abhishek, sir, or Dr. Vaddi?
So, I have a few comments, sir. Would you like to make your comments first?
Abhishek, you please do it. Abhishek, you do it.
So, a very nice presentation, Dr. Himnath. See, one thing in this particular subset of audience, you remember one thing. See, there are absolute indications of doing something, and there are relative indications. Off-clamp techniques are the techniques that you embark upon initially in your career accidentally, and then you choose to do a select subset of patients using this technique. This technique has a real advantage in a very small subset of patients, say a single kidney model or a double kidney model which has CKD 3 or 4. Here, every minute of ischemia beyond a point is going to be extremely important. But to get to a point where you really use this technique, you have to train yourself. Therefore, you have to select simple cases of 2 kidney model, attempt this, then only you will have the skill set to use it when you actually require it. So this is the long and short of the technique. Now, when you the best way to embark on this technique is you every time you have a very simple case, start to do some Gilvernet dissection. Every time you do a Gilvernet dissection, you get a sense of how the vascular anatomy is going to be. Read the anatomy very, very well. Now, there will be a point in time where you will get a tumor which is supplied by a significant segmental vessel. You will be able to dissect this segmental vessel, clip this segmental vessel, and go ahead and do this off clamp nephrectomy, partial nephrectomy. A very, very important off clamp partial nephrectomy sometimes is a polar nephrectomy. There is a large polar tumor, and you from the main artery you see segmental vessels going to the tumor. One by one, you keep clipping these small arteries, and by the time you get into the parenchyma, you have taken all the vessels, and you just then walk through the parenchyma. So this is another important indication of doing off clamp nephrectomy. Remember, it is an important technique. The true utility of this technique is in very small subset of patients, but when it is required, it is really required. To embark on this, you will have to train yourself in every case so that you develop the subset to help the small subset of patients who are going to really benefit. So train yourself in every surgery you do, and there will be a time you will be able to do certain subset of patients without clamp.
Yes, yes, sir.
Before Shashank Agarwal, I will take 1 minute. Nearly 66 audience are there. As a secretary ASU, it is my custom to introduce the chairman. In the beginning, we could not do it. The Abheesh Hegde is the Abhishek, with your permission. We have not introduced.
Yes,
He is Father Muller Medical College Associate Professor, and he is a very good academician, worthily selected as the youth chairman. He is presently assistant professor. He is one of the young urologist delegate to represent at Korean Urology Association. Even for Leadership Forum 2025 UAA is selected. He is selected to represent India at Korean Urology Association 2025 meeting as first prize consultant quiz Eurolithicon 2025. And he also has big list of the achievements, travel fellowships, studies conducted, publications, book chapters, research activities. I didn't know this. I was going through because I asked in the just before the conference. Phenomenal made CV. One should make the CV like this of 18 pages, because when you want to make the CV, after seeing the CV, I thought I will inform you people, youngsters. Everything, whatever you do in that month, you add to your CV. Whether you will put it in a short form or big form, different issue. But the moment year goes out, you will not remember what you have done. You might have done a major thing, but after 1 year, it looks that you have forgotten. So after seeing his CV, I was very impressed. So I will share some time in the group. Very nicely made CV. All the best, Abheesh. You should represent and work more hard to go further heights. With this introduction, sorry for this 1 minute. Next speaker, please.
Next speaker, Dr. Shashank Agarwal. Shashank is a colleague of mine from MPH. After passing from MPH, he had the same dilemma, that whether to subspecialize or continue practice as a generalized urologist. Then after he practiced as a general urologist for 1 year, and then he came to the conclusion that he has to subspecialize. So he went to Kochi. He has done a uro-oncology fellowship and robotic fellowship there, and now he will be talking about the same topic. Over to you, Shashank.
Yeah. Can you see my screen, sir?
Yeah.
Good evening, everyone. Greetings from Hyderabad. At the very outset, I'd like to thank ASU as well as BioU for giving me this opportunity to speak on the topic which very commonly and deeply resonates in every early career urologist, that is whether to opt for the subspecialization or to go for generalization. So following the footsteps of Western countries, the Urological Society of India has also embraced the subspecialization concept, and it has formally launched various subspecialties like endourology, uro-oncology, renal transplantation, etc. With the advent of these subspecialties, there is a tremendous growth within the field of urology, and it also has bring various an array of opportunities for the youngsters to pursue their careers. But in addition to that, it has also brought difficult challenges rather, in making the decisions where choosing one path is often considered closing the doors for others. In a recent survey conducted on 85 Indian urology residents, primarily final year residents, the author found that more than 75% of the residents want to do subspecialized practice in their post-residency period, and approximately 90% of them are inclined towards the academic practice. And close to 60% of the residents have got enough exposure in their residency, which will help them in choosing which subspecialty they want to pursue their career. But the story does not end here. On a closer outlook, apart from the endourology, which is being widely accepted and imbibed in every training centers, rest of the specialties are being suboptimally accepted. Say for robotics, pediatric urology, female urology, androurology, they are all grossly underrepresented, and hence it reflects a deep gap between the aspiration as well as the reality. So of late, we have seen that many of the novice urologists opt for subspecialization driven by FOMO, which is fear of missing out rather than pursuing their genuine passion. Novice urologists also get influenced by their peers that what they are pursuing, and this is a classical example of the bandwagon effect. If you look into the current context, like there is a boom of robots and advances in the endourology, and many of the youngsters want to align themselves in this line. And there is a fear amongst themselves that if they don't get aligned, then there is a fear that they may left out. So here are some practical considerations which one has to take into consideration while making the professional decisions which is going to shape their future practice. The number one is demand and supply ratio. We have to look whether already any subspecialist is already existing in the particular city or region. And we have to see, are the general urological services are saturated or is still in demand? Second is the type of the institutions where the person wants to apply, whether the hospital encourages the subspecialty work or not, and are there any multidisciplinary boards, research or teaching avenues present or not. Third is the financial viabilities. As we all know that the subspecialization may have a slower start financially compared to general practice, and the return of investment has also to be assessed. Will the chosen subspecialty allow early income generation or does it require long gestational period? And fourth is the referral network issues. Do you have adequate access to the referring physicians who will understand and value your subspecialized skills? And will your peers support and compete with your niche? The personal factor also plays a vital role while you are choosing one option out of two. First personal factor is aptitude and passion. Do you genuinely enjoy to practice a subspecialty and excel in a particular area? Because subspecialization requires lifelong learning in a focused domain, and are you ready for that commitment or not? Second thing for the personal thing is work-life balance. What kind of lifestyle suits you the best? What thing of lifestyle are you looking for yourself in a long run? Some of the specialties may require high stress environments like uro-oncology or some of the emergencies in the endourology. So are you ready to imbibe this, to face this or not? Third thing is that where you want to practice, because subspecialists may need to be present in the metro cities or in the tier 1 cities for adequate patient volume and for proper infrastructure. So are you willing to relocate in these kinds of metro cities if needed? And whether you are having the courage to leave, are you prepared to set aside your broad skills which you have learned during your residency and fully commit to mastering in a single subspecialty? So in addition to your personal thing, you have also to look for the professional growth which you are looking for in a long career term. So first thing which you have to look in the professional growth is career trajectory and identity. As we all aware that subspecialists may build a unique identity and academic research profile in a much faster way, and we have to inquire ourselves that whether we have the aspire for publications or speaking at a focused conferences or not. Second thing is the mentorship. Do you have the mentors who will guide you in a particular way? Because the role models often shape long-term satisfaction in a career path. And the third thing is that innovation. The sub-specialization will allow us to adopt the recent technology in a short period of time, and the general practice may limit you to broader but more conventional treatment paradigms. So now let us look what are the advantages of pursuing subspecialty in the urological practice. First is the improved patient outcomes. Subspecialists are able to perform perform complex procedures with a greater procedure expertise, and they also have a better clinical decision making. Several studies have shown that the complex procedures which are being performed by the subspecialists have given the higher success rate with the fewer complications. Second comes the technology and techniques. Subspecialists are more adept and quicker in learning new techniques like robotic surgeries, laparoscopic, laser enucleation, microsurgery, etc. Coming third point, academics. Subspecialists contribute to high impact research like cancer genomics, newer treatment modalities for urolithiasis, and so on and so forth. Meeting the patient expectations is the fourth point. Today's in the modern world where everyone is having access to the AI and Google, today's patient often see that who is the best treating doctor for the prostate cancer in their area, who is the best doctor for the kidney stone laser expert or laser surgeon. So in a metro cities or in a tier 1 town, awareness is high among the general population, and hence subspecialization will help to meet the patient satisfaction. Coming next to the professional satisfaction. Subspecialization will allow the urologist to develop a particular niche, leading to greater professional satisfaction, recognition, and opportunities for becoming further future leadership in their particular field. And while we specialize, we can unmet subspecialty needs, as we all aware that pediatric urology and andrology remains grossly underserved in Indian population because of the limited exposure during the time of residency, and hence focused training will ensure better care for all the groups. Coming, what are the advantages of being a general urologist in urological practice? First, fragmentation of the care. There is a widespread concern about further fragmenting of an already fragmented healthcare system, especially in a country with vast underserved region. So while after creating the subspecialty, we are further doing the salami slicing of an existing urological backbone. Second thing, as majority of the Indian population is still reside in the non-metro and rural areas, and 70% of the urological works in these areas belongs to the BPH, stones, and UTIs management. So why not to pursue the career as a general urologist? Third point is uneven patient distribution. As we know that subspecialists will not get enough case volume in the smaller cities, but they can get adequate volume in the big cities, while vice versa applies for the general urologist. Fourth, we have to keep into economic considerations into account, as subspecialty training comes with a high cost, and many of the urologists cannot afford additional years of training because of their family or some personal reasons. And subspecialties may struggle in private setup unless they are being attached to a large corporate hospitals having good financial backup. And the return on investment, the subspecialist may not recover the initial cost if the patient volume is low. Fifth factor is inadequate residency exposure. The residency offers broad exposure but limited subspecialty training, leaving many undergraduates or postgraduates unprepared to specialize. And the last one is the healthcare policy, where the lack of policy incentives, insurance coverage, and government focus on high-end subspecialty care. As we all know that the government focus mostly on the general services and outreach and not on the specialization. So to conclude, there is no one-size-fits-all solution. Each individual career path must align with the individual goals and circumstances. Although the subspecialization represents a logical progression in the modern neurology, offering improved patient outcomes, but in the Indian context, this adaptation of subspecialization must be context sensitive and must be balancing between high-end urban care with the needs of underserved rural population. So in the beginning of the career, every novice urologist should evaluate what is their existing clinical skill set and clinical exposure and the place where they want to get practice in the future in a long term, whether they want to settle in the urban areas or in the rural areas. And they should also think on their existing financial stability and the family commitments and what is their personal passion and what they are looking in a long-term career vision. Thank you for your patience listening.
Nice presentation, Seshank. It's very difficult in the initial period to decide. Sometimes time gets wasted first 5 years before realizing that everybody will not get good opportunity, fellowship. So during the MCH only we should have strong vision where we did not have. Now we are doing everything. In future also I feel another few years there is no problem in practicing general urology, but don't get disheartened if you are not selected for fellowship or anything. Keep the focus on it. After some time you can change. So after 2-3 years also you can enter into the subspecialty. Life is long journey, so there is no need to worry about it. But going into one specialty and doing more work will give better outcome to the patient. Forget about your referrals and all that. But outcome also, if you are constantly doing one surgery, definitely outcome will improve. Thank you.
Shashank, very nice presentation. You never let the audience down with your 2-cent advice. And that is what our experience was when you were at MPOH. Very, very important, if there are any residents or people who are going to take new jobs and have not yet decided about their subspecialty at this point, it is very, very important that when we choose a institution for a first job, or when we choose a institution for residency, the first question that we ask is, cutting kitna milega? How many cases will I get? So rather than this, the question should change, and what kind of exposure will I get should be the question that in your mind. Will I be able to see all the subspecialty work? Is there good pediatric urology volume? What about the andrology work? Is there some functional urology also happening? Oncology and endourology, by and large, all institutions are going to do. So these are the questions that you should ask yourself if you are taking the first job with a broad specialty intent, and if you are doing your residency. This exposure will enable you to choose what subspecialty you should be following. So in the initial 5 years of your career, including 3 years of your residency, you should try to empower yourself to make a good decision about your subspecialty. That should be your objective. And if it is possible, not everybody's social circumstance permits this, but if your social circumstance permits this point, keep the remuneration as the second important thing, if possible. I know it is not possible with everybody. Some people have compulsions of life, but if you are given that opportunity, keep remuneration as the second most important thing. Look at gaining a wider exposure, and you'll automatically know what you are headed for, because your gut always directs you in the right direction. So at this particular time, follow your instinct or gut. You will definitely head in a right subspecialty direction. Over to you, Gopal.
I think
Yeah.
yeah.
So
Also, I think Dr. Gopal, Dr. Abhishek sir, I think the role of a mentor has been stressed in a lot of talks all throughout in many of the USI programs. I think that is also another thing that somebody has to keep in mind when they're taking a fellowship. How good the mentor is and how much of a leg up they're going to give you in your professional practice. Anything, sir? Anything on that?
Surely, surely, there are two roles. One is like if I am Chandramohan sir's student, he can place me anywhere in the country. This one feeling is important. But apart from that, that role of a mentor is very, very important. But apart from that, it is how the value of a mentor is inspirational. You know, if means so I have what my teacher, Dr. Sabnis sir, he never does a minimal access work. He doesn't do a robotic surgery. But has he allowed me to do everything that I desired? He's always allowed me. So the value of a mentor is inspirational. If I have a problem anytime in making a decision, what will he do? I just think about it, and the answer is there on the plate. So if the teacher is extremely inspirational, he will always show you the path. So can he place you anywhere you want to go? That is one aspect. But does he inspire you to get the best in you is another and the more important thing.
Yes, sir, rightly said. So we'll move ahead. I will ask Dr. Vivek Mayappan, he's from Chennai, to give the next talk on the lymph node management in the penile cancer. Dr. Vivek?
Yeah, I'll just share my screen right. Yeah.
Dr. Vivek is in
Yeah.
Bharatanagar Indo-American, and recently when we conducted the conference, he helped all faculty who have operated there. I appreciate your patience and skills of managing the OT for these consultants to do a live workshop. It also is important. Good.
Yes, sir. Thank you. Thank you very much for the opportunity as well, sir. At the outset, I would like to thank the Youth Organization of USI and the Association of Southern Urologists for giving me this opportunity. Good evening, everyone. I'm here to present on the lymph node management in penile cancer. The penile cancer is an uncommon malignancy which an adjusted incidence of about 3 in 100,000 patients in India. It's most commonly present in elderly men in the sixth decade of life, with high incidence when HPV infection is present. As in any penile cancer, TNM staging needs to be done. Once the patient has been staged, patient has to be risk stratified as in the low, intermediate or high, the low risk being till PTA1, G1 and high grade being the PTA1, G3 up to PT1B and above. Once the primary treatment of the penile cancer is done in the form of penile preserving surgery or partial penectomy or the total penectomy, the management of the lingual lymph nodes needs to be sorted out, which is an integral part of any penile cancer management. So clinical N0 groin is defined as a no or palpable enlarged lingual lymph nodes, no suspicious nodes on ultrasound, or a palpable or enlarged suspicious nodes but are negative on the FNAC. The incidence of clinically palpable lymph nodes in Indian literature is around 20%, and in case of a clinically node negative patients, there is micrometastatic disease in these subset of patients of up to 25%. Older series reported that penile carcinoma patients harbor infection around 30% when there is a palpable inguinal lymph node. However, the recent series have reported that metastatic involvement is present in 70% of clinically enlarged lymph nodes. So this warrants in the evaluation by imaging of finding out whether there is palpable or clinically identifiable lymph nodes. And ultrasound is one such tool wherein there is specific criteria to describe these lymph nodes based on the shape, central hilum, and the peripheral cortex, which has a sensitivity and specificity of about 40% to 100% as specificity. Which are available include the CT scan, the PET-CT, and the single photon emission computerized tomography to delineate the inguinal lymph nodes and the pelvic lymph nodes. Once the risk stratification is done, in case of an intermediate or high risk, these patients need to be subjected to CCT chest and abdomen pelvis, and subsequently subject these patients to what is called as surgical staging. So once the clinical lymph node drawing is being delineated, these patients are risk stratified as low risk or high risk or intermediate risk. In these low risk of patients, surveillance is advised. And in case of a high risk patient, there is a high possibility of having 30% of lymph node metastatic risk. And these patients need to undergo an inguinal ultrasound with FNAC and a surgical staging, which in the form of a dynamic sentinel lymph node dissection or a modified inguinal lymph node dissection. Even though these patients undergo surgical staging, these patients have to undergo an inguinal ultrasound and FNAC prior to this is because in case there is a positive lymph node in the FNAC, these patients can directly be subjected to a therapeutic radical inguinal lymph node dissection in about 20% of patients. So the surgical staging includes the form of either a dynamic sentinel lymph node biopsy or a modified inguinal lymph node dissection. The dynamic sentinel lymph node biopsy has underwent a sea of change, starting with the initial introduction of the concept by Cabana for penile cancer to today's world. So this dynamic sentinel lymph node biopsy initially started out with the sensitivity of 80% with a false negative rate of about 20%. With subsequently standardization of the procedure with the specific induction of the injection and the specific methodology of usage of these procedure, this has significantly reduced the false negative rate to the current value of about 5%. We implemented this in 2022 and thereby found that our study also was in line with the world literature, which gave us good results. Next in line is the ICG, where Brower et al. Implemented this with the usage of the green dye, which is the ICG, and there was an advantage of having a low cost, elimination of radioactivity, and there was documented long-term safety. However, it came with a disadvantage that it had a poor penetrance through the adipose tissue, thereby requiring an incision which needs to be placed. This study compared the usage of radioactive colloid like technetium-99 along with blue dye and the green dye, and found that the green dye, which is the ICG, along with the fluorescence, had a comparable rate when compared with the blue dye. So what we implemented very recently is the usage of combination of the blue and the green, along when compared with the other individual dyes, found that the combination had a higher significant detection rate with a low false negative rate, and it avoids the radiation exposure. Next in line, the surgical staging is the modified inguinal lymph node dissection, which involves a smaller horizontal incision and limiting the field of inguinal dissection by avoiding going laterally to the femoral artery and caudally to the fossa ovalis and the preservation of the saphenous vein and avoiding the transposition of sartorius muscle. However, this has a disadvantage of having a higher complication rate when compared to the dynamic sentinel lymph node dissection. So this image shows the modified inguinal lymphadenectomy, wherein the focus is given to the sentinel node area, which is the superomedial grade 1 and the central group of lymph nodes. Next, coming to the management of in case of a palpable inguinal lymph node. In case there is a unilateral lymph node, which is less than 4 centimeter, which is a clinical N1, these patients needs to be considered for a bilateral radical inguinal lymph node dissection. The new set in town is the fascia sparing inguinal lymph node dissection, wherein this is made it to the guidelines, where the fascia is preserved, which is the facial data is preserved, and along with that, saphenous vein is spared and the sartorius transposition is not done. However, with the same set of boundaries as in the radical inguinal lymph node dissection. Any form of inguinal lymph node dissection comes with its own subsets of complications such as the infection, skin necrosis, lymphedema, seroma, and lymphocele. There are meticulous controls of the lymphatics can be done with absorbable sutures, and the lymphedema can be avoided by saphenous vein preservation, and the wound infection can be used proper sterilization, and the usage of horizontal incision reduces the incidence of wound dehiscence and skin flap necrosis. There's a small variation between the clinical staging and the pathological staging, being that clinical N2 is actually pathological N1, where there is 2 or more lymph nodes, with the pathological N3 being extranodal extension or the presence of pelvic lymph node metastasis. Importance is given to the extranodal extension because it has a very poor prognosis as such when there is an extranodal extension in these sets of patients. This was a study done in our country wherein the importance of the extranodal extension needs to be given for the pathological subclassification in pathological N3, being that pathological N3A has only extranodal extension, and when N3B having pelvic lymph node metastasis with or without extranodal extension, because just with extranodal extension, the overall survival was significantly around 36 months when compared to 17 months. However, with the recently introduced the 9th edition, the staging has been the same as the 8th. When considering the bulky nodes, which is more than 4 centimeters, or in case of bilateral lymph nodes, the patient has to be considered for neoadjuvant chemotherapy prior to the surgical procedure in the form of cisplatin-based chemotherapy, which is considered for 4 cycles of paclitaxel, ifosfamide, and cisplatin. And when neoadjuvant chemotherapy is being given to these subset of patients, they have a better progression-free survival and overall survival. In case of a node 3 disease, such as this, where it is fixed and matted, these patients need to undergo a complete excision with the usage of a musculocutaneous flap for reconstruction. Pelvic lymphadenectomy is done when 2 or more inguinal lymph node metastases are present with extracapsular lymph node dissection needs to be done when present in the inguinal lymph nodes. In presence of a positive pelvic lymph nodes, they carry a worse prognosis when there's only inguinal lymph nodes when compared to the pelvic lymph nodes. And in case chemotherapy has not been given prior to the surgery, adjuvant treatment needs to be done because the disease-free survival is significant when adjuvant therapy is being given. Currently, there is no role of adjuvant radiotherapy in the management of lymph nodes in the adjuvant setting. So to summarize, in clinical N0, surgical staging needs to be done. Clinical N1 and N2, radical inguinal lymphadenectomy needs to be done. In case of a clinical N3, neoadjuvant chemotherapy followed by radical inguinal lymphadenectomy needs to be done in these patients. With the implementation of the robotics into all the procedures, the video endoscopic inguinal lymphadenectomy has come into play, and the results have been promising, with there is the perioperative outcomes being almost same when compared to the open inguinal lymph node dissection. However, the oncological control has requires further verification. This was a study done in our country wherein they found that the robotic and the open approaches were comparable, but the guidelines suggest that for clinical N3, open is the way forward, but for clinical N1 and N2, both the procedures can be done. Regarding the follow-up, in case of the penile preserving treatment or in case of amputation, the first 2 years is every 3 monthly, and the year 3 to 5 is every 6 monthly follow-up is required. To summarize, in clinically N0 groin, a risk-based approach needs to be done, and accurate staging in the form of the surgical staging needs to be done, and good surgical principles needs to be followed for groin node dissection, and whenever in doubt, a usage of myocutaneous flap reconstruction is advised. Thank you.
Thank you, Vivek, for comprehensive talk on the lymph node management in the penile cancer. Abhishek, sir.
Thank you. Yeah.
So Vivek, very nice presentation. You've covered all the aspects of a groin node dissection for cancer penis. I have a small comment to make. Generally speaking, we always goes down whenever you use minimal access technique. From an eyeball standpoint, this also looks to be true for groin node dissections, but it is not a free lunch. Whenever you see when you do a lot of retroperitoneal lymph node dissection with say cancer bladder, that is pelvic lymph node dissection, or for kidney cancer in the retroperitoneum, you still get a lot of lymph. And same is the situation when you do the groins. You tend to get lymph will drain for a long time. Only thing is the skin related side effects or the problems may be less. So a word of caution, if you are planning migration from open to minimal access, yes, it is beneficial, but it is not that you will face no problems when you are doing minimal access groin node dissection. So beware if you are heading towards R wheel. Be cautious, you'll still have problems. Be prepared, because most of the people who do these surgeries and who do it well, like your center, they have a lot of volumes, and people who have good volumes tend to do good job out of these malignancies. Most of the centers in our country do not have good volume for penis. and testis. So when you embark on a groin node dissection, though anatomically it appears to be a simple procedure, to consistently give good results, you should have volumes.
Certainly, sir. Yeah. That is good.
Chandramohan sir, any comments?
Yeah, nothing. I have least experience in management of post MCH carcinoma penis. No comments.
Okay, sir. So we'll go ahead. Thank you,
I
Vivek.
think there's one chat box. There's a question, sir. For DSLNB, how many agents do you prefer? Methylene blue plus ICG or single agent is sufficient? Dr. Shashank is asked.
Yeah, the thing is, we are currently we are doing a study comparing the double dye and with triple dye, wherein the double dye includes both the methylene blue and the ICG when compared to all the three dyes implementation for the groin node dissection. Our paper has been accepted for the ASU program as in representing from Telangana state. So we are happy in that sense. But a single agent, as of now, I don't think so is sufficient. When the guidelines also suggest the radioactive colloid along with the blue dye. Hybrid technique using the ICG is coming into play in a big way. But then using a single agent might not give the adequate results, is what I personally feel. But it's in future to see.
Right.
So,
And
Shashank,
Dr. Vivek, yeah.
Yeah,
if your
yes.
question was that is ICG replacing
Methylene blue.
dynamic sentinel lymph node biopsy, presently the answer is no.
No.
But teams are working. So ICG is basically a byproduct of minimal access urology. And because the technology is available in minimal access urology, both in lab and robot, we tend to use it more and more. But presently, it does not replace dynamic sentinel lymph node biopsy.
No, the issue or the rationale behind asking this question was that nanocolloid is not easily available in each and every center. And it has issues with the what kind of noise you get. So whether can ICG can replace this one nanocolloid was my just query.
Yeah.
Yeah,
That is
so
why.
presently, so the answer to that question is it has not yet replaced. People are working on it to gather evidence. Yeah, noise is an issue, device is an issue. Everybody doesn't, even if they have the technology, everybody doesn't have the handheld probes. There's one center in the city which has it, so on. There are only a few cancers which have real indication of sentinel lymph node biopsy. So making such a big purchase for such a small subset of patients may become difficult. So therefore, they are looking for other technologies, but it is not yet there.
Okay, sir. So we'll move ahead. So next talk is by Dr. Ravi Tauri, renal hilar masses intrahilar dissection. Over to you, Ravi.
Yeah. Am I audible?
Yeah.
Yes.
Yeah. Good evening, everybody. At the outset, I would like to thank the Association of Southern Urologists, Dr. Chandra Mohan sir, Dr. Abhishek, Dr. Abheesh, for giving me this opportunity. My presentation will be on renal hilar masses. I'll be concentrating more on intrahilar dissection. I currently work as a consultant uro-oncologist at HCG Cancer Care Hospital in Bangalore. So, a short disclaimer that this is not a comprehensive discussion on this topic. I'll only be highlighting some key aspects. So, as we all know, the renal hilar tumors, they sit in and around a major highway of incoming segmental vessels, main renal vessels, and the ureter and the pelvic luteal system. And through this traffic, we need the intraoperative navigation, which is best done by a 3D reconstruction. A drop in ultrasound probe is always preferred during the renal hilar tumors. And of course, ICG, as we have seen in the previous talk, where sentinel nodes are picked up, it is also very useful during renal surgeries. And a bedside good assistance, experienced assistance, and a supportive OT staff is what is generally required to embark on such surgical tumors. Another pressure point that we had spoken about in the last topic by Dr. Hemnath, he touched upon warm ischemia time. And this beautiful paper by Dr. Dipen Parekh published in 2013 specifically looked at this point where warm ischemia of about 30 to 60 minutes is acceptable in a two-kidney model where both the kidneys are working. And this gives us more leeway when we do renal hilar tumors, where the warm ischemia may exceed 30 minutes, and this is quite acceptable in the current scenario. But in a situation of a solitary kidney is where every minute counts, and beyond 30 minutes is where it really matters in a solitary kidney. So with this background, I will present two cases which we dealt with in the last year. So the first case is a 49-year-old male. She was detected with a left renal hilar mass during her investigation for UTI. She had no comorbidities. Her creatinine was normal. And then we counseled her and we... am I audible? Hello?
Yeah, audible.
Yeah. So, and her creatinine was normal, and then we counseled her for a robotic partial nephrectomy. And this was done under a general anesthesia where a left ureteric catheter was deployed before docking the robots. Standard port placement was done for this partial nephrectomy. So this is a short surgical video. This is a 3D reconstruction of the CT that we had gotten before. And this shows the tumor sitting in between the renal segmental vessels, tertiary vessels, and it sits on an infundibulum of the upper pole calyx. And this is a totally endophytic tumor with no exophytic component. So after a usual colon drop that we all do, we control the hilum. Two vessels, primary vessels, were controlled with the vein. Gerotas was opened, and we could see that the tumor was totally endophytic, and this would also give us the opportunity to understand that for totally endophytic tumors, better to go for intrahilar dissection rather than a top-down approach. So we do this carefully, entering into the Gil Vernet's plane parallel to the renal vessels, keeping the renal vessels at the bottom and the parenchyma on the top. This is a slow, very meticulous dissection where all the renal sinus fat has been taken down slowly. The movements are small and calculated to avoid any risk of bleeding. And now I have sped up the video just to highlight that the initial dissection is very meticulous. All the vessels that supply the tumor are clipped. The one in white is the one which is supplying the tumor is clipped here with the hemolock, and all the sinus fat is subsequently taken down. So we slowly embark within the renal sinus fat and locate the tumor deep inside. With the help of 3D reconstruction, we get a fair bit of idea preoperatively and intraoperatively where to head in this maze. So here we are dissecting the renal vein, a segmental branch close to the tumor base, and the one in white is the one we are going to ligate, and the one in blue is the one which we are sparing. So these are the two vessels which we initially located going into the tumor, and now we are decided to score the tumor, the parenchyma around the tumor and over the tumor. We head in a long non-clamped way to score, but for the actual resection, we clamp. Of course, in this setting of intrahilar tumors, bleeding is expected, so renal vessels need to be clamped. And we embark deep into the tumor. Here, the calyx is open, which is identified with a gush of urine. Because we could not And here we get to the other side of the tumor. The infundibulum is noted on which the tumor is sitting, and the calyx at the periphery is excised around the tumor so that the infundibulum is spread here. And the parenchymal excision is carried all around, and now all the segmental branches, all the tertiary branches to the tumor are clipped, identified, and all the main branches are spared. So here we try to lift the tumor from the base, and with the help of the overlying parenchyma, we retract the tumor so that we get into the base and around the tumor without getting into the tumor itself. So the dissection is carried out from the base and now going to the sides. And behind all these tertiary branches to the tumor are sequentially clipped and cut. So it is important to clip all these branches so that later on they do not require to be repaired, because suturing these individually will take a lot of time on the on clamp. So the calyx that was opened at the periphery is sutured separately with an absorbable suture. Now we do a standard sliding clip rhinorrhaphy, which is possible in this because the rent is deep and the parenchyma is approximated without much tension on the base of hilar vessels and the pelvis. So this is not always possible, but whenever possible, we try not to do this rhinorrhaphy very snugly so that the underlying vessels are not compromised. So once this is achieved, the clamps are removed to see any bleeding, and the gerotas is closed over hemostatic agent that can be used of choice. So this is the follow-up of the patient after 6 months, where you can see the left kidney is quite nicely perfused and there is a scar which can be appreciated of the rhinorrhaphy. There is no recurrences till now. So this is another case of a 31-year-old female who had an incidentally detected left renal mass in the hilar region on health checkup. She had no comorbidities and her creatinine was normal. Similarly, a left ureteric catheter was deployed and the patient was taken in a right lateral position and standard ports were raised and robot was done. Similarly, I'll run through this video quickly. The hilum was controlled and the gerotas was opened. Here, the ultrasound probe came in very handy because this was again a very endophytic sort of tumor, no exophytic component. So the tumor was localized. This can be viewed in the ultrasound quite nicely. And the marking was done, parenchymal marking was done with the help of this ultrasound, which comes in very handy in such situations. So similarly, the Gil-Vernes plane is entered and slowly we dissect with meticulous dissection techniques to get into the tumor area. This is another thing that I would like to highlight is a neuropathy. This is a neurosurgical sort of gauze that they use, which can be utilized in our surgery with ease. It is a delicate gauze piece which can clear the field very effectively and can be pulled away from the field by the assistant surgeon without disturbing much of the surgeon operating. So once we gain control of the main vessels, we enter again similarly with meticulous dissection techniques, slow and steady, and clipping all the vessels that are supplying the tumor. Now, in this case, we encountered the collecting system, which we clipped And now as I cut, we can appreciate the papilla here. So similar dissection is carried out slowly into the tumor bed. Here we use ICG, but as we had clipped this vessel supplying, we went in an off-clamp way because the area parenchyma over the tumor was devascularized. So this was predominantly done off-clamp, and all the bleeding that was encountered was cauterized, and it was able to be managed in this way. So the dissection proceeded all around. Once we encountered the bleeding, cautery was used judiciously, and all the dissection was carried out. When we encountered this major bleeding, we clamped, on-demand clamping was used, and the tumor was safely taken out in a good field. So here the vessel that bled was taken care by suturing it separately. The clamps were removed to see whether the bleeder is stopped effectively. Here we separately close the calyx again. We utilize the ureteric catheter to flush just to see the closure if it is adequate. If the closure is non-adequate, we take extra sutures. It is very important to close the calyx because there will be no parenchyma to support in the renal hilar region. So closing the calyx is very important to avoid urinary leaks. As in this case, the parenchyma is not able to approximate. We use this garland technique where only the cortical sutures are placed to effectively control the bleed, and intermittently the clips are applied like a sliding clip technique to support the parenchyma. The crater is packed, and similarly the gerotas is closed above this. So these are the two rhinorrhaphy techniques that can be used in renal hilar tumors where the crater is present. This is the similar technique that I showed, the garland technique by Gao. And this is another technique, the VHS technique described by Dr. Jehad Tok, where the two sutures are placed in this direction so that a triangular defect is made and an outer rhinorrhaphy is performed in this fashion to close the tumor bed. So advantages of intrahilar dissection is that inadvertent entry into the major renal vasculature and pelvic ileal system is avoided in a bottom-up approach rather than a top-down approach. And maximal intrahilar dissection is done off-clamp. So the worm ischemia time is limited. Option of super selective clamping and clipping of tertiary vessels is always there so that they are not to be repaired in an on-clamp setting. So repair of major vessels can be avoided or limited once we are on clamp, and the worm ischemia time can be limited. So the take-home messages from my end would be a good pre-operative and intraoperative imaging is required to get this roadmap. CT with thin slices and an angiogram phase is necessary, mandatory. 3D reconstruction, ICG, and intraoperative ultrasounds are adjunct. If they are present, the surgery becomes even more precise and safe. Patient counseling and communication is very important. Need for angioembolization, conversion to open should be explained to the patient. There should be always an option of radical nephrectomy kept on the table. These 3 points of anatomical complexity and no CKD and a new baseline EHFR, if it is more than 45, then radical nephrectomy is also a very good option rather than embarking on this hilar tumor dissection and partial nephrectomy. Of course, from the surgeon's point, patience and precision during surgery is the key, and post-operative care holds the key for the patient to return home without complications. So I leave with this quote by Dr. Jehad Tok. and where we should prioritize vessel preservation over speed, and we should always aim for trifecta, that is negative surgical margins, maximum preservation of renal function, and no complications. Thank you so much for the opportunity.
Nice presentation. And good cases, both the cases. Any comments, Gopal, Abhishek, and Abhish?
So, Dr. Ravi, I have seen that you are applying too many clips in the bed of this renal fossa where you are resected the tumor. So we have many cases, 2-3 cases where these clips has eroded into pelvic system, and it has formed stone over that clips. So what is your point on that?
The clips, they can get into the pelvic system. That is why, to avoid clipping on the pelvic system, particularly close with the suture whenever possible. On the vessels, tertiary branches, clips are acceptable if we close the above parenchyma very tightly. The pressure effect would allow the clips to migrate inside the pelvic system. If there is no pressure above, the migration is quite unlikely. But it is not unheard of. So what, as an alternative, we can do is apply metal clips, where we go underrun the metal clip and remove the metal clip. So that is another alternative if the migration of clips is one of the aspects that you're considering.
Okay, Dr. Abhishek.
Ravi, whenever there is a crater-like defect, like you rightly showed, one of the ways of doing it is the garland rhinography that you showed. Another is something like a crown rhinography. So you, like the way you do a sliding rhinography, you put in a clip, get into the parenchyma, take 1 bite, 2 bite, and then get out of the parenchyma as if you were getting out on the opposite side and put a wet clip here. So in a horizontal mattress configuration.
Okay.
On each side, you just keep coming in, then create a horizontal mattress, go out, put a clip. When you're coming in, put a clip, then go take 2 bites of parenchyma, create a U, and then go out and put a clip. So at the end, you will see a crown. The base of the crown will be formed by hemlock clips, and the spirals of your V-lock will give you projections like crown. So I call it the crown rhinography. That is also one of the ways of managing this situation. And depending upon, I think these all techniques have been accidentally discovered or invented while hilar masses were being done. So that is also one technique that can be used.
Yes, sir.
Okay,
So
thank you,
can
Dr.
go ahead?
Ravi. I will go ahead with the next talk by Dr. Manas Ranjan Panda, novel technique of removal of multiple renal calculi using an endobag before robotic calculus. Over to you, Dr. Manas.
Good evening, everyone. After an intense discussion on uro-oncology, this is something which is related to more of a general urology. I'm here to present a case of a 42-year-old gentleman who had no comorbidities, who presented to us with an ultrasound and a CT which did not have films, a diagnosis of left multiple renal calculi with hydronephrosis. This patient was stented outside and was referred to us for further management. So we got a CT scan done, which showed the stent was in place and a huge load of stone with multiple small calculi in place. This is the coronal view, which shows the middle calyx and the lower calyx being filled up with multiple small renal stones. Sagittal view shows a confirmation of the same. So we got a DTPA scan done to rule out any PUJ obstruction, which confirmed the diagnosis of a PUJ obstruction. There was reduced tracer uptake on the left side with increased transit time. The right kidney had good function, and the percentage function was 30 and 70%. So the considerations before we offered the patient with the options of the surgery were we ruled out any crossing vessel, the degree of hydronephrosis, and the renal pelvis size was analyzed. The ipsilateral and the overall function was seen, and any other anomalies present were ruled out. The coexisting stone load, which was very huge, accordingly the patient was offered the options. And finally, the patient preference was chosen. So we offered various options like minimally invasive pyeloplasty with pyelolithotomy, and other options which were given were staged procedure with PCNL and endopylotomy, or PCNL with followed by a lap pyeloplasty. Other open options which were offered to the patient outside were an open pyelolithotomy with pyeloplasty. So the patient, the rates of stone clearance and the chances of stone clearance were explained with the various procedures, given that the open will definitely, as it is an age-old method, will have higher stone clearance rates. Also, the staging of the procedure was also explained. The patient wanted to proceed with a single-step, minimally invasive procedure. So we went ahead with the robotic procedure, and we began with the mobilization of the colon and exposure of the dilated pelvis. Here the ureter is being exposed and the pelvis is being dissected completely. There was a small crossing vessel which was coagulated. After marking the incision for the pyeloplasty, we made a wide enough incision to expose the stent, and already we can see there are a few stones which are popping out from the opened up area. This is a bag which we use usually for specimen retrieval. So this bag was sutured to the lower end of the pelvis. After suturing it, the other end of the suture was hung up so that we can prevent any kind of stone spillage. It was made even with all the precautions. There were a few stones which had spilled out in the meantime. We collected them and pushed it into the bag. Then a suction was used, and the stones were pushed out into the endo bag. As we can see, as we give suction, due to the whirlpool effect, the stones are getting collected inside the bag. After doing this for around 30 minutes, we thought there are no more stones coming out, and then we finally proceeded by checking it with by inserting a flexible cystoscope. We checked all the calyces, and still there were a few stones which were remaining, which we cleared out again. After that, the bag was sealed off, and we proceeded with the standard Enders-Heinz dismembered pyeloplasty. We exchanged the stents, and this was the number of stones. There were more than 200 stones which were collected, and this was the post-op X-ray of the patient, which showed complete clearance. So the principles of pyeloplasty, which is basic, were all kept in mind. It was a widely patent, watertight anastomosis, tension-free, and funnel-shaped with a dependent drainage. This cannot be overlooked during any kind of case. The total operating time was 150 minutes, with the console time being around 110 minutes. There was 50 ml of blood loss, and there were no post-op complications. The patient was discharged on second post-op day. The use of an endoscope for checking the clearance during a pyeloplasty has been described previously as EARP. Although the use of a bag for stone delivery was something which we thought of, especially for this case, as the patient insisted on a single step procedure. Most of the studies which have been shown are in pediatric population for combination of both the pyeloplasty and stone removal, as we can although the number of patients which were in the study and the stone load was pretty low, but the stone clearance rates on using an endoscope were definitely good, with amounting to around 70% after the use of an endoscope, and 90% after a secondary or ancillary procedure. The the treatment of stones complicated by the PUJ complicated by stones has can be approached minimally invasively, and this was the purpose of doing presenting this case. The when we are using a minimally invasive technique, the highest risk is of stone spillage, which can be presenting later as a peritoneal as a picture of peritoneal carcinomatosis. It can also cause intra-abdominal adhesions, abscesses, granulomas, or implants, which can mar the picture, and the patient might land up after a year or something with other kind of complications. This is also one of the innovative techniques which has been described as carbon dioxide based nephroscopy during the time of pyeloplasty to ensure increased stone clearance rates. The limiting factors in treatment of PUJ with a large stone load is the clearance and the efficacy and safety of the procedure. So a use of a nephroscope can definitely help in ensuring the stone clearance rates. The rates of secondary PUJO with the primary PUJO is higher compared to compared to where there is no stone load. Although in this technique, the normal time which we will take for a pyeloplasty would be around 60 minutes or 45 to 60 minutes. Although the operating time is increased, the invasiveness of the procedure is definitely decreased. And by using a bag, we wanted to prevent a stone spillage. So when faced with such cases, we can always think out of the box and to provide the patient with a lesser invasive procedure and a single step procedure. The basic principles of reconstruction should never be overshadowed, whatever the approach be. Thank you. I would also like to thank Abheesh and all the ASU for giving me this opportunity to give my presentation. Thank you.
Nice innovative idea. PCNL is always an option in such cases before clearance, and put a nephrostomy and then do dissection. It is mildly discussed, but you, in your perspective, have shown nicely. A good number, 200 is not a small number. PCNL is also not easy. Very well done. Okay. We have last presenter. We should give importance to him. I always feel that last two presenters should not be made hurry.
Yes.
Because they will be waiting and initial persons will be taking time, and we should not. So last person will be given ample time. Sandeep, don't worry.
Sir,
Happily you present your
one
time.
comment for Manus.
Gopal.
Manus. So if you use a flexible scope while removing the stones, that time with the irrigation, that ball will float, and the ball will come into the play inside the view when you are doing pyeloplasty.
Correct.
So that is a disadvantage if you do intraoperative this flexible nephroscope, because of irrigation, ball will float up.
Yes, sir.
Correct.
Manas,
We
I
used
also
one of the pros to put the flexible cystoscope and then went in just to check the calysis without using any much of additional irrigation for that.
So the flexible cystoscope goes through the 5 French?
Sir, we used a 8 mm robotic port as an extra port, so we did that.
Biorat scope goes, not to mention the name of the company, it goes through the 5 French scope.
Sir, instead we can use a flexible ureteroscope also if
very difficult. That's why I asked you. Got into
the length of the scope.
It is very difficult to manipulate at a long length like laparoscopy. Yes. Exactly, you pointed out that it is very difficult.
Yes, sir.
Because the flexible component of a flexible ureteroscope is about 8 centimeters. So you need a play of 8 centimeters to do something.
Yeah.
You don't have a play of 8 centimeters. One instrument that I have found very useful for this particular indication is a short ureteroscope. Not everybody has it available, but short ureteroscope is a 33 centimeters ureteroscope and it is 8 French. So when you are say dealing with a lower polar stone, you for the left side anatomy, you put it from the left hand port, right diagonal. On the left hand side, you put it from the right hand port, right hand working port for the upper pole, or similar working ports in robot and lab. Got that. So this is a very, very important thing. Like what Gopal was mentioning, that if there is a lot of irrigation fluid, the bowel will float. So you have to have your suction inside. Gradually keep sucking. Irrigation is there, suction is also on from the other side. So this will prevent this particular situation happening, and then you can manage this. See, if you can control the number of stones in a laparoscopic milieu, then only embark on this. Otherwise, you will land up in a bigger mess. Then it is better to do PCNL or
PCNL.
something. So be sure that you can manage the number of stones. But compliments to you, very well managed.
Very well managed.
Moving to next speaker, Dr. Sandeep. Practice in Metro City as a young urologist, navigating the challenges.
Sandeep is also active in youth urology. I came to know recently. Very good. Keep it up. Sandeep?
Dr. Sandeep?
Unmute.
Sir, I'm online, sir. Just give me a second, sir.
Yeah.
Yeah, it is already visible.
Okay. Acha,
Make
can
it
I
full
go
screen.
ahead, sir?
Yeah,
Yeah.
go ahead. Enlarge the screen if possible. It is visible.
Slideshow.
Slideshow. If it is not happening, sometimes slideshow won't pop up. So you can close and reshare. You can get it. What is the problem, Sandeep? Hello?
Just a minute, sir. Rajendra is helping me.
Okay, no problem.
Yes.
Patient.
Okay, can go ahead now. Unmute yourself. Dr. Sandeep, unmute yourself.
Sir, unmuted, sir. Sir, can you hear me, sir?
Yeah.
Sir, I'm Dr. Sandeep, sir. I'm based in Hyderabad, working in ESI and also practicing, sir. Sir, my topic today is practice in a metro city as a young urologist, navigating through the challenges. Sir, most of the presentation I have made slide by myself, and these are the issues which I face during practice. So I don't know how many of them can accept it and or anything, but it goes like this, sir. Sir, today I'll discuss very briefly, sir. It takes 45 minutes about establishing a new practice, clinical challenges, regulatory and compliance issues, and work-life balance. Sir, first and foremost is financial considerations. It is the most important, which I feel right now. From securing funding to managing overheads, it takes a lot of time and effort and mental tension. So we usually secure funding through self any monies there or loans or grants or investors or parents or anything. This funding is not just for an initial push, but it also for to maintain for at least half an year to on a year at least. And maintenance, if budget, if we cut down budget by limiting performance and all, it might cost us. So we should strike a fine balance between performance, work, that is marketing, patient's experience, ambience, salaries, rent, all the expenses. And the main question comes here is, for how much do you charge for a procedure? Right now, this has been a very important thing here in my practice, because recently I faced a very bad issue that I was called to a hospital for stent removal. So I did the stent removal and I asked for money. They gave me 2,000, saying that this is how we charge. This is how much we charge. Then I said, who gets instruments, who gets everything, who spends time to do just for example of 2,000. Then he said, sir, if you are not there, there are many people, many young urologists in the city who are ready to do for even lesser price than this. Just because we call you regularly, we are giving at least 2,000. So be happy. That's how I was treated. And at the end, I could not do anything just to accept money and go off. Then I started thinking, why is it like this? Why didn't we standardize rates for a freelancer or a young newcomer for at least standard procedures? Because at least we do only 5 or 6 endo procedures hardly. So most of the freelancers, they do only those procedures. Those rates are also not standardized. These are the main challenges which I faced in the city as I've been practicing from the past few years. Subject and all, anyways, we read books, we watch our seniors, we go to conferences, we open YouTube, we attend conferences like this so we can get our skill. But no one is there to guide about charges or self-respect or how to deal with this, because most of the times we don't deal with the doctor. We deal with only MODs, manager on duties, or some non-medical person who doesn't know anything, but we have to take money only from him. So what I feel is we have to form a group, a standard group, where they can fix a uniform rate for all these procedures. So I've been successful. We have been successful in forming a young urologist group, at least in Hyderabad. We meet once in 1 month or 2 months, and we share our experiences. But nothing has come out of it. This was today. I went for a haircut. There I saw these are the standard rates displayed there. So no one does a hair cutting with shaving less than 230 rupees in the first thing. I don't know if it's clear or not. So these type of things should be standardized, and it has to be made, because once the MCH is completed or fellowship is completed, they don't know how to talk and how to deal with all the other hospitals outside. So this is what I feel. It's high time that we have to form a standardized rates and go ahead so that it will help the hospital, patient, and everyone. So after the payment, I mean, after the financial things, once we get profits, I usually believe that we have to invest initially in instruments. Later on, we can do other investments. And most important right now, which I also felt at one point, is work-life balance. Because after working for so much time and roaming for so much time, I feel very much burnt out. I don't know how to do what to do, and so this is what I felt, that we have to compartmentalize work for this many hours only, unless there are emergencies, friends, family, and a me time. Me time for pathetically for most of the doctors, they don't have me time, because most of them, they grow up without having any hobbies also. So this is how the work-life balance should be made. For the it includes personal well-being. Most important is mental health awareness. First of all, thinking that we are doctors, we should not be in denial. You just sleep or take a peg of whiskey, then everything will be set. I don't think that works every time. If not, it works few times, but not every time. So we should always understand the early signs of anxiety, stress, or depression. Because one of my friends, he went into depression because of the huge amount of practice, but he realized it after getting out of the practice. So he took a professional help. Then I thought that we should not, uh, neglect these early signs of all this anxiety, stress, or depression. So immediately we have to seek appropriate resources, that is professional help. And also, this is I've spoken about the mental health. Then the next is the physical health. It always impacts our work performance. So at least we have to work out 30 to 45 minutes per day, at least 3 to 4 times a week. And a diet also should be included, is balanced diet and sufficient sleep. So this is a presentation, sir.
I think,
Something
Dr. Smith,
interesting.
congratulations. You started thinking on these lines. This is the most important thing. If you have a thought process in this, and that these things matter, then it is half of the battle won.
Yes,
I'm not the right person to make comments on the rates of prior practice or freelancing. One thing is surely known,
Rajendra, can you close the screen?
that freelancing practice it leads to more burnout than a stable practice. So if you are doing a freelance practice, then you need to protect yourself more. Everybody is in a typical situation in his own life. Means I cannot say that freelancing should not be done, or you cannot say that institutional practice cannot be done. So everybody has a situation to deal with. And if you are doing freelancing, the least you can do is protect yourself, and protect yourself well. Protect yourself well from being exploited. Protect yourself, give yourself a good mental health, give yourself physical health to last long. At least in some areas, work on your own terms and conditions. That means if somebody calls you at midnight to operate, you can conveniently say no. If somebody says that I will not, you come here and do the case, whatever the case is. If it's a 40-year-old with LUTS, you just come and see the patient and do TURP. You refuse. Don't accept everything. So what you would have done, the indications that you would have followed during your training, you should follow only those indications. Protect yourself well. And like you said, me time, it's very, very important that you spend this time in developing concentration skills, mindfulness, so that you are able to fight the battles of stress very well. Thank you, Sandeep. You brought out very, very
you-
Can I make a comment? Chandramohan?
Yes,
Yes,
sir.
sir. Please, Mallikarjun Reddy, sir.
Yeah. I've been listening to the whole webinar, and it was nice. I think the scientific topics were fine, but the ones which were actually non-scientific were of great interest to me. I have seen everyone putting up the problems, and then the problems we know very well. But I think very few of you have come up with possible solutions which are needed. I think that is where we need to work. I think I commend Sandeep on this, just at least raising the issues of pricing and the young urologist group. The young urologist group is actually doing a good job. I tend to get to know the whole thing when they come together. But this is time which they actually start off putting in some effort. What I have actually started at this point is I've collaborated with IIT Mumbai. The things are on process to actually look at what is the cost of capital investment for each procedure for a urologist. So there are parameters which we have taken, and then probably it will take time. So a lot of people have said the initially whatever money we get, we do, and then we go ahead, it's a numbers. At the end of the day, if you're earning ₹1 lakh a month and 12 lakhs a year, and at the end you are paying for about 5-6 lakhs a year for your instruments, I think you are not doing an appropriate job. You may have your own money and setup, but that's not appropriate practice in a private practice. You should never go back in red. Please make sure that your capital investments are, the capex is definitely looked into. You need to actually have a return on your investments because you have to upgrade. But I think the bottom line here is coming together and then delivering the goods and then charging for it. Please do not undervalue yourself. The unfortunate part is today we charge very less for a TUR or a URS where we study for 3 years more. We invest in instruments where people charge a bomb for a hernia repair. So we are far more better than the general surgeons at any given point of time, and we have more credentials than them. I think we should also learn to say no. And I was the one who used to say that either you call me, don't call me. This is my charge. You have a poor patient, tell me you want to do service, I'll do it free. But today there is no poor patient, because for a poor patient there is Aragyasri. For a poor patient there is a government hospital which is fully equipped. So Sandeep, get the group together and then look at when you do freelancing, make sure that beyond this level we will not do. The moment we all of us say no, and we will have 10% black sheep. They are not going to go anywhere. A 2,000 rupees at one point of time in a month will not give you anything, not even sometimes your week's petrol for what you roam. So we'll need to learn to say no. Thank you very much for the time. I've been taking a little time here, but thank you for the time, Chandramohan, Abheesh, and then Abhishek, all three of you. Thank you.
Okay, sir. Now, Thank you for the suggestions and excellent committed presentations by the speakers. Now I will request.
1 minute, sir. 1 minute, sir. I think Dr. Reddy, sir, Dr. EVR Reddy wanted to make a comment. I was
AVS
told, sir.
Reddy.
Yes, yes, yes,
EVR
sir.
Reddy. AVS Reddy, sir, just called me.
AVS Reddy, sir. Yes,
Sir,
yes, yes, sir.
Rajendra, give unmute him, Professor AVS Reddy, sir, who is very senior, and he was listening and he called me that I am not able to give comments.
Yes,
If you can, AVS Reddy, sir, please, sir. He is very senior. Honestly speaking, he is the one who has given my first RIRS live workshop at Kurnool Medical College way back in 2010. So it was the first workshop I did in Kurnool Medical College because of him. We remember. He attended and he was appreciating all of you.
Sir has to mute himself, sir.
Huh?
Mute himself, sir.
He has to unmute himself. Sir, ABS Reddy, sir, can you unmute yourself, sir? Meanwhile, we ask Dr. Abheesh and Abhishek and Gopal, please give your comments, closing remarks. Then, if possible, we'll discuss it, sir, or else we'll conclude the session. Please. First, Abhishek. Unmute.
So Chandramohan sir, first and foremost, thank you very much that this ASU has given us this opportunity so that our colleagues from the Young Urology Group are able to present themselves. So that it has given us a voice. ASU is the first zonal group that has given us a voice to speak. That is very, very important. All the young members put up their points across wonderfully, extremely eloquently. And a shout out to Dr. Sandeep, who really brought out the ground situation to fore, that this is the real problem that we are dealing with. And unfortunately, if I have a difficult renal tumor, a book can teach me, a YouTube channel that is very, very well there. There are platforms like Pure which can teach me how to do this. But if I am suffering or getting exploited in practice, unfortunately, there is nowhere to go. It is only my colleague or only my family sometimes to head to. So programs like these, organizations like YOU, organizations like Southern Urology Association, West Zone, North Zone, East Zone, and USI, the onus is up to us to help our fellow members to get out of this ditch. Thank you, sir. Thank you very much.
Thank you. Dr. Gopal, please.
At the outset, I would like to thank Dr. Chandramohan sir, Dr. Abhishek sir for conducting this session. And in this session, we tried to cover the majority of South Zonal areas, and we have given the opportunity to the young urologists to present their topics and their problems, which we immediately after passing out, they come across. So they have put very well, they have covered very comprehensively all the topics, including Dr. Sandeep. Thank you, sir.
Dr. Abhish.
Good evening, sir. First of all, thank you to the President, the Honorable Secretary of the ASU, sir, for giving us this opportunity. One thing, of course, as everybody else has put in their points. One thing that I would like to tell people about you is that the forum does exist. It is up to us about how much opportunities we are able to utilize. There is help for whatever projects you want to do, or as we've already seen, coming together in a city to practice. Probably one thing is teamwork, which I have personally experienced in my own surgical career, as far as learning is concerned, or else even as to work on a day-to-day basis. Your team is very important. The times are such that we are kind of getting fragmented more and more. We are getting more and more closeted into smaller spaces. It is probably the other thing that we have to do, that we in a general life sense as well as in our practice. I think we need to come together there are a lot of things that we can do when we come together, and YOU has been trying to promote, trying to get more people to get involved in the USI programs, with of course the cooperation and the opportunity given by the seniors. And so we would be I've been very happy in the way everybody has tried to come up with their own topics and been very professional in their presentation in the interactions prior to this, and hopefully after this also. Thank you again to the ASU Council for this opportunity. Thank you.
Thank you, Abheesh. In fact, the concept of YOU is good, and it is going to increase everywhere in the world. It is encouraged. Two things, female urology and YOU, are encouraged. We also respect that. So I asked Abheesh and Abhishek and Gopal. So they were kind enough. They only made the program predominantly. And my job is to ensure that the program happens. And we have added also YOU program. I request Abhishek to join our ASU in Vijayawada, all of you. And all the speakers are different. None of the speakers are repeated. So that again 10 people will get chance. One more term is there for me. Minimum I can give 60 talks for YOU so that they can also expose their knowledge. With this, we will conclude the program. Once again, thank you, Abhishek. Thank you, Gopal. Thank you, Abheesh, for accepting to conduct this program. Thank you all the speakers and the audience. Reasonably good audience, around 55 to 60 all around were there 2 hours. For a webinar, it is very high attendance because I conduct regularly. 10, 15 will be there, but good attendance. Thank you very much.
Thank you, sir.
Thank you, sir.
See you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.
Thank you. Thank you.